Hello. Hello.
Hello. ये ले, दे लो।
यार हेलो.
Okay, Ji, thank you very much. Uh, we are going to talk about empyema, and none of us has ever this opportunity to not to see this patient. Our OPDs are overwhelmed with these patients. And today, what I'm going to talk about is how we receive these patients and what are the different modalities and when should these patients be shifted and what are the treatment modalities we can offer so that the patient can have the treatment for this disease. Uh, if we think what are the stages of empyema, do we really get these exudative staged empyema in our OPDs? I think the answer would be majority of would you say no. And what we get usually is the fibrinopurulent, very rarely, and the most common is the chronic organizing empyema, which is always there with the tubes in the chest and patient in OPD with prolonged ailment and with sepsis and with treatment with low hemoglobin. So if we summarize, biochemical empyema treated in the West, and what we are struggling is with frank purulent chronic empyemas. The principles of the treatment, I think this onus goes to everyone sitting here. The antibiotic regime to control the sepsis, we know it, the pharmacological support, and then the second knee-jerk response should be the provision of adequate drainage. And by adequate drainage, we would encourage to have an intubation of these patients as early as possible. So this part of the treatment, if it is done, I think most of the time the story can end. But this is never done, and what we'll end up is that we have the patients who have collapsed lung, who have got residual cavities, and then we have to do something for the obliteration of the space so that, sorry for the inconvenience, so that the lung is going to expand and cover that cavity. And this is how usually the patient comes once we open them. Now, if we make it simple, these patients with empyema, we are talking of chronic empyema, either present with bronchopleural fistula or without a bronchopleural fistula. If this patient comes without a bronchopleural fistula, then usually you do, if the facility is there, VATS, maybe uniportal, you can have multiportal, and recently small mini thoracotomy combined with the VATS, you can always do it for minimal NCN. Or the old standard technique of thoracotomy and decortication. But what would you think once the patient has got a bronchopleural fistula? This lung is not going to expand. This lung is not going to fill the space. So you have to do something. Either you decorticate and primarily close this bronchopleural fistula, and then cover it with either a muscle flap or a lung flap. And sometimes, despite of doing this, this lung does not occupy the native chest cavity, and you are left up with a residual space. Then I always say you have to indent it, because if there is a space, there is a pus, there is an infection, and then there is be no resolution of symptoms. So either you indent it by removing the skeletal support in the form of thoracoplasty, or you put in a muscle, which usually in tuberculosis emaciated patients are of very low volume, but still you can combine it. And then sometimes you combine all these procedures. What to do in patients who are physiologically unfit? I think you can do an irrigation and rib resection. At least no antibiotic is going to reach that pus until unless that pus is drained. The principle of the chest cavity remains, as the pus is there, you have to drain it. And then VATS, local debridement, you can at least do to decrease the sepsis. And sometimes you can't do anything, patient is with hypoalbuminemia, and you have only the option is that either you make a tube window or you make a plurocutaneous window. For malignant cases, the only option is just a chest tube or a Plurex. Don't try to operate these patients. Now, I'll just share what we have been doing, and this is an experience of a series of 1,084 cases, and this is a descriptive case series. And this data is going to show you in the tertiary care hospital of thoracic surgery department over 16 years, what type of procedures we are doing and how we deal with these chronic empyemas. These all patients had chronic empyema and they were unfit for, and the exclusion criteria was patients who were unfit for one lung ventilation and patients who had these malignancies or hemothorax. So we excluded them from the study. Now this is the spreadsheet, and if you see, this is the number over the years you get, and there is a dip in the COVID era, and again then it increased, and overall number is about 1,000. In this slide, you can see that 826 thoracotomies were done and 258 VATS procedures were done. And if you see the subacute empyema, we had only 90% of these patients. Out of 258 chronic empyema, 168 chronic empyema had a VATS decortication. So overall chronic empyema, you have 994 patients. That comprises the 91% of the influx of the OPD. And only 8% of this patient, we could get it, which had a subacute empyema, where disease was slightly early, otherwise the presentation, as already said, is always late. These are the procedures which we do, and I would explain you if you just look at this log. This was the log which I presented in Boston, and this is a published log of the patients of chronic empyema, as I highlighted, with no bronchopleural fistula and with bronchopleural fistula. With patients who have got no bronchopleural fistula, either it is loculated or generalized. For loculated, you can do a mini thoracotomy and decortication. For generalized, you can do a standard decortication, removing the peel, or a VATS decortication. For the patients with bronchopleural fistula, the thing is the lung expandable to fill the cavity or not? If the lung is expandable, you can do a primary closure with a muscle flap or a lung flap to ensure that there is no leak and the lung fills the chest cavity. But if it is a non-expandable lung with collapse and consolidation, then conventional thoracoplasty plus decortication is done, or you can do a tailored thoracoplasty and decortication in muscle flap. The combination of this is because in tailored thoracoplasty, the number of ribs removed is less. So the patient has less deformity and lesser pain as compared to conventional thoracoplasty. If the patient has endobronchial symptoms, that means he is having hemoptysis, or on CT you have cavity and necrosis as shown in the previous picture, then you think of resection. Otherwise, resection in an empyema is forbidden because it gives rise to bronchopleural fistula and you always land up in trouble. So we would not recommend resection until unless the patient earns it. In a fibrous collapsed lung, you can just do a thoracoplasty because the lung is not going to bleed, the lung is not going to have infections because there are no cavities in it. But if the lung is necrosed, there are cavities, then endobronchial symptoms are there, then you have to do the resection and let's ensure that you cover the stump with some muscle flap to avoid, again, the bronchopleural fistula. Why this is ensured? They all have polymicrobial infections. They all have tuberculosis, and the chances of blowout in these patients are very high, and we need your help for optimization, for proper treatment of these patients before sending these patients, and we always use our pulmonologist for this once the patient is stabilized. So this is the same log, and see what our data is. So without fistula, loculated we had 98, and normal procedure which is usually done to fill the lung is standard decortication, and it was in 526, 70% of the patient. Patients with fistula in expandable lung, 75, we have thoracotomy, decortication, and primary closure. In non-expandable lung, we have these thyracoplasty in 46, combination in 34, and resectional surgery with muscle flap in 47. This we have been doing for the last decade, and these are the patients of chronic empyema. It is your convenience, either you do it uniportal or you are doing it multiportal, depending upon that the peel has to be removed and you enter the cavity. That is what is required. I hope so this slide runs. It's just a few seconds. And maybe if we could make it out. This is how with specific instruments, this is the chronic peel over the lung, and you can just remove the lung and peel off this cortex which was covering the lung. So there are different methods. You can use scissors, you can use these instruments which are specifically made for decortication. This is the use of scissor. And you try, the advantage of this is that you can even remove the parietal pleura also. This is a blunt technique. And you would see that this is how the lung is expanded. And we ensure that the lung is going to touch the chest wall on expansion. So if the lung is not going to touch the chest wall, then we have to think of adding some procedure for which we have taken the consent of the patient before the procedure. Now this is surprising. Despite of all, still negating it, 45% of our patients are having tuberculosis. And most of these patients, once we get the pus out of them, the material which was purulent, that murky water which was there, that reveals no cultures. So usually we take it as a sign that if the cultures are negative, then the likely chances of tuberculosis are very high. And this is all the young age group. You could see mean is 32, and then we have gram positive and gram negative. I think this is just the surgical complications. We required blood transfusion, and the patients who had a prolonged air lake with the minimum mortality in this procedure of these patients. Now, just to show you the pictures, what prototype we get. We have this. You have polymicrobial infections. These are the air bubbles. You have put in this chest tube. You are very happy the lung is going to expand. But the lung never expands. You see, this is the pus and how the antibiotics are going to reach here. So you remove this peel. This is how the lung is going to expand and going to come out from the chest wall. And this is the postoperative X-ray of this patient. And this is the thickness of the peel over the lung, which is not going to allow this lung to expand. Similarly, this is what you get. You have this CT scan with all air bubbles. And this is the expanded lung and post-op of this patient. Loculated empyemas. Majority of these are because of tuberculosis patients who have got a residual collection. So you have this D sign or a pregnant lady sign, and then you do a decortication with a small incision, minithoracotomy, and the lung is expanded. This is how the cortex is. You can remove it, or this is the lung, you are removing it, and this is another case of loculated empyema. Patients like this, tuberculosis with the bronchopleural fistula, you have a peel inside. You remove the peel and then try to either primarily close or choke it with the muscle, what I was saying. And then this is how the lung expands. And very rarely you find patients like this with loss of hemithorax. This is what it is inside. The lung is not expanding despite of decortication. So just to fill in the space, you have to remove and do a thoracoplasty, and this is how the lung expands later. Another patient with thoracoplasty. This is the patient in which this shadow you could see. To cover the multiple bronchopleural fistula, we use the latissimus dorsi flap. And this is how the necrotic lung sometimes you get, and you can remove it and then cover it with the muscle flap. But what can we do for these patients? And it's not rare that you find these patients like this, lying on the bed, you can't do anything. And then the best would be for space sterilization to have a plurocutaneous window. So these were few of the publications we had from the department. These are available on Google. This was the paper presented in Boston also. These are the also publications. And what take-home message I would request, few of the things are level 5 evidence. I think it would be difficult for you to swallow. But this is over the last 16 years what we have gathered this experience I would be sharing with you. The first thing would be drain the biochemical empyema or avert empyema as early as possible. And I know that everybody knows what is a biochemical empyema. So if you don't drain it, this is going to drain the energy of the surgeon, energy of the patient, and economy and everything. Ensure complete lung expansion. You have put in a chest tube, is it in the right place? You do an ultrasound, and if you think there is a controversy over it, but I would say that a suction should be applied if the patient doesn't have this, that the lung should expand and fill the space. Early referral for VATS and specialized thoracic interventions. If you think that the patient is having polymicrobial infections, patient has got some time, he's not responding, there is a residual cavity, on X-ray, on ultrasound, on CT scan, repeat, send these patients. Now this is again a gray zone, moderate to large tuberculous pleural effusion. Early intubation and will avoid the loculated empyema. I'm not talking of mild effusion. I know the pleurisy is being managed medically most of the time. If you have moderate to large effusions, the tap is once done and it occurs again. The preference would be to put an early intubation in this patient to avoid the consequences of CP angle blunting and the loculated empyema, which is a fate of patients of pleurisy with tuberculosis. Patients with bronchopleural fistula, if you have, the chest tube is bubbling, give them a 2 months treatment, prepare them accordingly, and then we would have this patient with all pharmacological and nutritional support. Patients without bronchopleural fistula of TB, the time has come, we can do early intervention. As we used to do a TB intervention, always takes 6 weeks treatment, it is not required. If there are no tubercular fistulas, you can have 2 weeks treatment and you can start the treatment of this patient. I think we have a topic of guidelines also in which he is going to talk about these lytic therapies and how streptokinase has withered off. So I would say this local lytic therapy in the form of simple irrigation with normal saline if the patient doesn't have bronchopleural fistula, or if a patient has a bronchopleural fistula, tell the patient to sit, tell your registrar to wash it with saline. It is going to decrease the pH studies are the limitation to diagnose biochemical empyema. If possible, we should do it so we can early intubate these patients. The last slide, pleural biopsy for the patients who are above 40 to 50 years of age, do take before going in or scope before going in, because if they are malignant and you have done a decortication, once a year we always have this type of patient. Then this is going to fungate and increase the misery of the patient. So if the patient has malignant empyema, either you tube it or you have a pleurax. I think this would be something over the years we used to negate it, but over the years now it would be difficult to swallow. Use of ATT in doubt situations, avoid post-operative complications of decortications as failure of lung to expand, prolonged air leak, lung is more stiffer, you can't suck it to the chest wall. So these are antibiotics. We are already giving them Azomax and Tynam and Fotam. You know these drugs better than us. So these are also, in my poor opinion, these are also antibiotics. These are not anti-cancer drugs. So if the patient doesn't have that pathology, that is always stopped. But if the patient has this TB and we are operating, we do get more complication of residual space and all the things which I have highlighted. So just the last line, primary goal should be space sterilization with drainage and pharmacological support by all the wise people sitting here, and that is going to solve it. But if it is required and the knife is required, then the secondary goal for the therapeutic assault would be to fill the space with the expanded lung, and if required, not possible with the lung, we have to obliterate the space with some thoracoplasty or muscle flap. I hope these things are clear. Thank you very much.